Hello, it's Jeremy Faust, editor-in-chief of MedPage Today. I'm joined today by Dr. David Callaway, who's the chief medical officer for an organization called Team Rubicon. Dr. Callaway is a United States Navy veteran and works as an emergency physician and professor of emergency medicine at the Carolinas Medical Center, where he is the chief of crisis operations and sustainability, and he is just back from Ukraine recently. Let's get to our conversation. Dr. David Callaway, thank you so much for joining us.
Thank you, Jeremy. Appreciate the time.
And you've been in Ukraine already, is that correct?
I have. My job is to, one, make sure that there's validated need. Two, to make sure that we have the capability and capacity to address that need. Three, to make sure that we've liaised and partnered with the right people. And then finally, to make sure that our teams are safe where they're operating. So that's what I was doing while I was over there.
And what was your initial impression when you got there? Like, what's the situation on arrival?
Yeah, so my impression was the surrounding nations are extremely, extremely generous and welcoming to the Ukrainian refugees. Once I got into Ukraine, Ukraine is a developed country with a great health system. They've had some challenges, but they were absorbing these 6.5 million, what is now 6.5 million internally displaced people, putting them into homes. The health systems were absorbing them in the West, and people they had this steely resolve. I mean, they knew what was going on in the East. They were still going 2 or 3 times a day, going down into air raid shelters because of missile warnings or attacks. But they were out sending their kids to school, getting coffee in the cafes, and really they had just this determination to continue living life while also preparing for what they thought would be the worst case scenario.
Right, and now it's a war zone, and now you're dealing with what I assume is the usual 2-pronged problem: the continuity of the existing medical care, which from your description sounds like was pretty good, and also the creation of a whole new category of problem, which is essentially frontline medicine. Right now, what do you think the biggest challenge is of those two, or is it just both?
Yeah, I think the biggest overall challenge is coordination of resources, as it usually is in a crisis. So you have 3 distinct problems. One is battlefield point of injury trauma care. That's mostly being done by the Ukrainians. There aren't a lot of Western NGOs that go to the front lines, and that's appropriate just given the conflict. Then there's internally displaced people, and then there's the refugees. I think that the story that we talk about is what is the impending tsunami, and that's the fact that we are still in the middle of a global pandemic. Ukraine did have some issues and challenges with like measles vaccinations and TB, multi-drug resistant TB. And now we've just taken the system, the system has been strained and broken in some areas and displaced 10 million individuals. So all of these conditions are likely to worsen. We have people who aren't getting their chemotherapy, people with heart disease who aren't getting their medications, kids who aren't getting their vaccinations, and now they're all displaced. So that is going to become the massive humanitarian crisis. Right now, the system has absorbed it. But we're starting to see some of the strain in countries like Poland and Hungary, and then especially in Western Ukraine, as time continues to go on and the situation continues to get worse.
So is the group that you're more concerned about the internally displaced person, the IDP, that is essentially, there's some degree of egress, so that's an externally displaced person, and the surrounding countries have so far been absorbing. You're saying that might be kind of reaching an endpoint, or at least a fill point, and so then the stress internally is becoming more of a problem on the IDP front. Is that fair?
Yeah, I think it's both, because what we're seeing and what I think will naturally happen is if there's a stalemate in the conflict, people will start moving back into Western Ukraine. And we already started to see this a couple of weeks ago because the west of Ukraine was relatively stable. So people had fled, started to come back, and this movement back and forth across the borders, just like anywhere where you have migratory populations, it's hard to provide care. And then this population in particular, of the 10 million, of the 4 million refugees, 2 million are kids. And of the 10 million displaced, something like 80% are women and children. And so, there's human trafficking issues, there's vulnerability issues, there's just the regular, challenges of caring for kids. That is going to continue to emerge with long-term consequences if we can't wrap our hands around it.
Tell us a little bit about what Team Rubicon is that's different from other NGOs, what you can provide. And then on top of that, like, what's the thing that you're having trouble providing? What's the greatest problem that you're facing right now?
Team Rubicon is a veteran-led disaster response organization and humanitarian aid organization. About 4 years ago, we were verified as a World Health Organization Type 1 mobile emergency medical team, which means that our mobile teams can care for 100 patients a day for 14 days without resupply. And we're basically, autonomous, or we're self-sufficient. So that is one of our core capabilities. It's been used for sudden onset disaster response like tsunamis and earthquakes. During COVID, we pivoted to provide a lot of COVID care around the world. And then this is our first foray into conflict zones. The unique thing about Team Rubicon is our balance of military veterans and then what I think are basically professional academic humanitarians. And so we built this, the way we operate is we have a network and we draw from this network. And the network is both veterans, but also partnerships with organizations, either formally or informally, like the University of Colorado. We work informally with Johns Hopkins and with Harvard, and then with my health system, Atrium Health in Charlotte. And so we're able to pull these experts to support missions, and they can pivot from infectious disease to trauma care to sometimes people are like, I need a Russian-speaking anesthesiologist. And because we have these vetted relationships with academic institutions, we're able to make those asks to be very specific and tailor our missions. What we're seeing in Ukraine right now is we went to provide care. Most of the care is covered, but there's a tremendous need for training. They want point of injury training, trauma care training, damage control resuscitation, and chem bio response training. We're able to pull on these networks of professional trainers and educators to support that need. And so the unique thing, again, is our diversity. We have veterans and we have humanitarians working side by side to provide the best care to people in their worst moment.
So then you, as you said before, you're not necessarily on the front line as you wouldn't normally be. On the other hand, you are training physicians, Ukrainian physicians, to do that kind of work that maybe they're not typically exposed to because they have a limited experience with that kind of a situation. Is that fair?
Yeah, absolutely. And one of trying to always be the optimist, but one of the dividends of the United States being at war for 20 years is on the medical side, we had a lot of innovation and we got very good at trauma care and resuscitation. And so this is an opportunity for people who spend time either doing that in combat zones or came back and helped do that and translate those lessons to care in trauma centers in the US to again be able to pay that knowledge forward, to share that knowledge with individuals who, you're right, in general weren't doing a lot of that work. And we can come in and help give them that capability.
So what's a lesson learned from a previous U.S. conflict, something that we maybe weren't doing in 2000 or 2005, but that now today is like standard of care, must know, that's the way to do it?
The classic example is the same stuff we do domestically now, right? So in 2000, tourniquets were anathema to care, right? Tourniquets, you put a tourniquet on, the limb came off, and you resuscitated with crystalloid. What we now know from Iraq and Afghanistan, and now is standard of care, I think, in U.S. trauma centers, is tourniquets are safe. You put them on for extremity bleeding. Hemorrhage is the number one cause of death. So you stop the bleeding and then you resuscitate with blood products. And so that is being applied in an accelerated fashion here as well, because tourniquets weren't commonly used in Ukraine. Now they're being supplied, training is being provided. But importantly, there's also an integration into a system, because just giving someone a tourniquet doesn't help if there's no system to take care of them after the tourniquet is applied. And so that's one is a lesson we've seen multiple times in conflict, but we're able to try to help work with partners in Ukraine to basically accelerate the implementation of processes, procedures, and a system to help manage that.
Is COVID right now a big part of this picture, or is it kind of in the background? Like what the fact this is all happening in the middle of this moment, tell me about that. Where's COVID playing into this?
So COVID is still a significant risk and a significant issue. I think people have lost focus on it, and to a certain degree because of the acuity of seeing hospitals bombed and hotels and apartment complexes bombed. But what I'll tell you is Ukraine had about a 36% vaccination rate prior to the conflict. When you take 10 million people and you cram them into a spot and then you move them around, whatever the infectious disease is, we know it's going to spread. And so COVID continues to be an issue. I'll tell you, it's an issue for our teams as well, because even though our teams all are vaccinated, they have to be triple vaccinated and have a negative test to deploy. We still have had people who've gotten COVID despite wearing masks and despite being vaccinated. None of them have gotten very sick, and we have pretty good protocols in place for testing and isolating when volunteers are overseas. but it's a big issue. And again, if you move all these people into other countries in Europe, measles, COVID, these highly infectious diseases, like it will become a challenge for the entire region.
Let's talk a little bit about the workforce that you help oversee. How are they doing?
The observation, as you would imagine, is that when there is work and when they are helping people, all of the other stuff fades away. The sense of mission and the sense of purpose and this commitment to team really is probably the top thing that builds resilience in anybody. And so when that's there, our teams are doing great. When there's a lot of downtime, I think there's time to think about it and it becomes more stressful. But again, what I've heard from all the volunteers returning is, one is a sense of thanks and gratitude to be able to go and serve. And the other is a sense of honor to have been serving side by side with other people who are willing to put themselves in harm's way to care for women and children and vulnerable populations who are, in the middle of a terrible conflict. That
brings something up, which is that a group like yours and others obviously held in enormous esteem and gratitude by the community, and there's some degree of like, oh, I want to help, I want to do something. Are there enough volunteers in groups like yours, or is it, well, we could use more, but it can't just be anybody because you have to have the right training? Tell me about the workforce issues for groups like yours, and for people who want to get involved. Is it kind of too late? It's like on this one, and well, get involved, and maybe on the next one you'll be ready to go. Like talk me through that.
Yeah, the workforce management of deploying volunteers internationally it is a tremendous challenge. What I would say is we always want good people. We're always looking for people who embody our humanitarian ethos and our core principles and our values. And so signing up to volunteer is something I would encourage everyone to do. I would encourage people to just act out their desire to serve, whether it's at home or joining a formal organization. I would not deploy or go anywhere by yourself. You put yourself and you put everybody else at risk by doing that. And then the other piece, I've said this a few times on interviews. What is at stake here is sort of our humanity, right? There's this conflict going on against two states that are supposed to believe in the world order, and one thing you can do right now or in 5 minutes is go be nice to your neighbor, go be nice to the people in your town, be a good doctor, nurse, paramedic, healthcare tech, just be kind to people, be patient, help embody the type of world that we want to live in, that is counter to this world of conflict and attacking women and children. Make it strong, make that the world we want to be in, and that's what's going to prevent things like this from happening in the future.
Well, I think we'll leave it right there. It's a great message to end on. Think globally, act locally, but and then maybe if you get involved, act globally and get involved with the
Act globally. Yeah, check out Team Rubicon, USA.org. Donate if you want to get engaged. Look at vetted organizations, whether it's us or International Medical Corps or Doctors Without Borders. Look at these groups that are vetted. Do your research, but it's a great way to get engaged.
Well, thank you for doing that on behalf of us and the species, and for joining us here at MedPage Today.
Hey, thanks, Jeremy. Really appreciate the time. Thanks for what you do.